I would like to thank all of you for joining this broadcast. The today's what we are going to discuss is a little bit related to the LDL. The first lecture will be on the LDL hypothesis, which all of us know that it is an important risk factor as far as coronary disease is concerned, and modifiable risk factor. So that I'm going to highlight the importance of LDL. Second part is when to use a therapy like PCSK9 inhibitor when the patient is having LDL still on the higher side. So other than the statin, what are the other options we have at present to control the LDL? And because we come across so many patients who has recurrent cardiac event, and at that time we really need to control the LDL to a very low level. So I'm going to highlight that thing also, and the importance of PCSK9 inhibitor use in which are the indications in the 2020. So that is what I am going to describe. Now we can go live with the video.
You must have heard so many things about the lipids and guidelines. This is just to show how basically to achieve the guideline as in our day-to-day practice. I don't have any financial disclosure related to this topic. Now, if we just look at the overall evidence of LDL, because of observational data, randomized control study, and the genetic study, it clearly tells that the person has a definite correlation of LDL with the atherosclerotic disease. If you just look at the beta-lipoproteinemia, where LDL is significantly reduced, they are basically protected from a cardiovascular problem. Whatever way you reduce the LDL therapy, it may be with the statin monotherapy or with a combination, the outcome benefit has been seen in various clinical studies. At the same time, when you drastically reduce less than 70, we can have even regression of theratomatous plaque. That has also been documented with the intravascular ultrasound. And clearly, if the percentage of reduction, absolute LDL reduction, if it is say 40, then practically 22% reduction in cardiovascular outcome can be achieved. This is the very recent study, 2019 Sweetheart study, that clearly tells that those persons post-MI, if their LDL is a lower quadrant compared to the higher quadrant, they have outcome benefit on the long run. So it was a very recently published study, and which was clearly demonstrating post-MI advantage of LDL reduction. 2019 ESA guideline is the new, which clearly based on the concept that LDL lowering, absolute reduction on the LDL is related to the reduction of the atherosclerotic disease. LDL lowering is better. Statin combination should be used. It is safe. And if you reduce the LDL to even 40, it is not having any disadvantage. And they have clearly told that whatever the etiologies, their primary, secondary, diabetic, non-diabetic, you have to reduce the LDL to significant amount. Previous guideline was clearly telling that 50% reduction should be achieved. That was the concept. But many of our patients, if they have start with 210 LDL and 50% is achieved, that means maybe around 120. Still, patient is having additional risk factor if their baseline LDL is more than 70. So that is the newer concept. And whenever required, you have to add ezetimibe and a PCSK9 inhibitor. Why this guideline have included 55 as a target? Because there are so many studies like IMPROVE-IT studies or Fourier ODC outcome data, which has clearly told them, which has clearly stated that when the LDL reduction is in the range of 55, the outcome in most of the patient is good. And that is the reason they have included 55 and not 70 in the recent guideline. Another thing they have identified is whenever you are treating, this is the patient with the IMPROVE-IT study, where some risk factor has been identified. And when a person is having this risk factor, the overall mortality is found to be very high. And in this group of patients, when overall mortality is high, if you use a combination of ezetimibe and simvastatin, the outcome is definitely better. And that is the reason they were specifically mentioned in the guideline that high-risk group of the patient should be achieving a combination therapy, because this study clearly shows the advantage of it. And that is the reason very high-risk patient, it is any patient with atherosclerotic heart disease, diabetes with an end organ damage, score is high, family history also with one another major risk factor. They have specifically told two things. One is LDL should be 50% reduction, and it should be also achieved less than 55. Those patients who falls into high-risk group of patients, like family history without any other major risk factor, diabetic without target end organ damage, moderate CKD, their target is found to be LDL. So this have included the recent guideline cardiovascular outcome because of this. Specific LDL targets, depending on the risk stratification, they specifically categorize the high risk and the very high risk patient also. And in the high risk patient, LDL should be less than 55. So this is a very, very clear guideline. If the very high risk group of the patient is there, then LDL should be less than 55. In moderate or low, we can accept all LDL of 100, and we may not try to achieve to the goal of 55. And we know that a combination of these three things, that is PCSK9 inhibitor plus high dose of statin and ezetimibe, can reduce the LDL to almost 85%. So depending on the risk profile and the target level, we have to use these three drugs in combination. As I've told, LDL should be reduced at least 50%, and also it should be less than 55. So both things should be achieved when we are targeting a patient, targeting the LDL therapy, especially in the high risk group of patient. Now, this is a patient, 32-year-old. He has a non-segment, ST segment elevation, MI. LDL baseline was 240. Patient at the time of discharge was atherosclerotic high dose. Patient was tolerating well. 30 days patient came, his LDL was 150. So according to the previous guideline, 50% reduction has been achieved, that nothing should be done in this group of patient. But new guideline clearly tells this is a high-risk group of patient and something more needs to be done. So one option is to switch over to simvastatin and ezetimibe. That is one option. But this is not a good option because already patient is on high dose of atherosclerotic. So there is no need of changing this molecule. The best thing to do is to add ezetimibe in this group of patient, because the guideline clearly tells that ezetimibe is very useful in this group of patient. So ezetimibe was started. The LDL on the follow-up was now 90. Okay, so it has almost achieved more than 50%, but still it is not achieving the guideline which has been published in this kind of high-risk group of patient. So definitely we have to consider a PCSK9 inhibitor in this group of patient. So if LDL goal is not achieved, we know it is different according to the risk profile. And if LDL goal we have to achieve 55, then combination of these three molecules is going to be very useful. Another patient is there where the patient is 69-year-old, prior history of MI. Patient has LDL of about 70 millimeter. Patient has recurrent of event. So in spite the patient's LDL was 70, now the patient is having recurrence. So what needs to be done? Because patients had multiple coronary artery blockage which was found. So guideline tells that it should be less than 55, that is one. But in this subset of patient, when patient is having a recurrent event in spite of second vascular event within 2 years, not necessarily of the same time, then LDL goal should be 40, not 55. So patient is already on statin, LDL is in the range of say about 70 or 60, but still patient recurrently, this is a real very high risk of patient. And this extreme high risk of patient, what we have to do, we have to have a target of 40. And we know that a target of 40 cannot be achieved without using a PCSK9 inhibitor. Another important thing is when patient come with the acute coronary syndrome, what we have to do, we have to repeat the LDL within 4 to 6 weeks. And as fast as we can achieve the LDL target, that is beneficial. So if it is not achieved by addition of ezetimibe, then within 4 to 6 weeks, we might have to start a PCSK9 inhibitor where a fast target level post-MI can be achieved. So PCSK9 inhibitor was started in this patient, and patient had LDL of about 60, which is what we want in our most of the patient. Another patient, always I tell, one of my patient here had angioplasty. Her son was in USA before say 7-8 years. He developed a coronary event. He underwent angioplasty there. Within 2 or 3 years, again he had a recurrent of event. That time angioplasty was not possible. CABG was done. His LDL used to remain almost like 130 in spite of taking high dose of ezetimibe and atherosclerotic. You were really worried because a 40-year-old guy having LDL of 130, he is a very educated guy. And what next to be done? At that time, this PCSK9 inhibitor started, US FDA approved, and he started using. In his whole life, for the first time, he could see his LDL in the range of 60 after starting a PCSK9 inhibitor. Attaining goal is very difficult. If you look at the various data, even 2019, only 30 or 40% of the patients are achieving the LDL in the range of what we want or a target. And that is a big problem, especially when we are using alone atherosclerotic, statins. If you use along with the ezetimibe also, statin and ezetimibe combination also, chances are very less. Only 30 to 40% of patients are achieving the LDL target. Lack of adherence is the main problem. Drug intolerance may be a problem. Failure to titrate and switch to the more potent drug of more high dose of statin and using an additional lipid lowering. That is the main reason why we are failing to achieve the target level. And this is the importance which has been shown. High dose of statin and high adherence, this has been done. Here, low dose of statin is used, or low dose of lipid-lowering therapy, and non-adherent. And if you look at the LDL changes, it's definitely going to be high. And outcome also, when there is a high intensity lipid-lowering agent and adherence is there, then definitely outcome is better. This basically tells that if you continue this for a longer run, definitely outcome benefit can be achieved. This is something we need to have a chronic sustained LDL reduction. It is not like sometimes LDL is come, then again going up. So if there is a variation in the LDL, then also the outcome is not good. So continuously, we have to have target level achieved to what we want according to the guideline. So what we have to do, we have to simplify the regime. We have to have a reminder, a patient's education, information. There are so many things we can always do to keep the patient adherent to the lipid lowering therapy. We may explain to the patient that outcome data are there, IBUS data are supported for the plaque regression, and event rates also can be reduced if you achieve your LDL to a very lower level. We can use an electronic gazette, and we can try to explain that your optimal risk at the end of 10 years is this, and if you achieve the LDL level to this, then definitely benefit will be there. So overall, if you look at high-risk patient secondary profile, it is class 1 indication to achieve the LDL goal of 55. Even in the very high-risk group with the family history also, it is class 1 indication to treat the LDL to the level of 55. Thank you very much.
I don't have any disclosure related to this topic. We all know that statin is important as far as secondary prevention or high-risk atherosclerotic cardiovascular disease is concerned. But definitely there is something beyond that. Okay, we know that another anti-lipid lowering agent also should be used. Now this is one of my patient where I did her angioplasty before 15 years. Her child, her son was was staying in USA, and he at the age of say 35 had undergone acute coronary syndrome and undergone an angioplasty at that time. And patient, unfortunately, after 2 or 3 years, again had a coronary event. And this time there was very significant severe blockage. So patient has to undergo a bypass surgery at that time. Now this person used to remain LDL in the range of about 130 in spite of using high dose of atorvastatin and ezetimibe. Okay, and that was a problem because at the age of the 40 years, he has undergone once or twice intervention, and now post CIBG, still his LDL is remaining high. And at that time, the PCSK9 inhibitor was approved in the USA, and the patient had started this molecule maybe about 5 years he is using, and now his LDL, after starting this molecule, as for the first time in his life, came to in the range of about 65. Okay, so that is the magic, or that is the importance of giving an PCSK9 inhibitor. So there are certain subset of patients which are high risk group where you have to give this molecule, and it is proved to be very beneficial in this group of patients. We all know that LDL reduction is very important as far as cardiovascular risk is concerned. We know that it can regress the plaque also. Okay, it is not only for the prevention or the progression, it can reverse the plaque also. And we know that statin, along with the other therapy, also has found to give a clinical outcome benefit. Okay, it is not that only statin is giving a clinical outcome benefit. We know that alone statin is many times not enough to reduce the LDL to the target level of 70. This is said that about 50-60% of the patients are not getting their LDL alone with the statin therapy, and then something needs to be done. If the recent guideline, if we follow 2019, tell that you have to have LDL reduction of 55, okay? Even 70 LDL target is not achieved by statin, then definitely alone statin or even with ezetimibe, we cannot achieve the target of 55 milligram. Another important thing is high-risk group of patients, when the statin was used along with the ezetimibe, is found to be more beneficial compared to the low-risk patient. And that is the logic of giving an aggressive lipid-lowering therapy to the high-risk group of patients because the benefit is there in this group of patients. Of course, we have to continue the high dose of atorvastatin because it has its own beneficial effect. So there is nothing like a low dose of atorvastatin and ezetimibe. High dose atorvastatin should be considered. This is the two trial which is regarding the PCSK9 inhibitor where they have given with the atherosclerotic disease 4-year and the ODC. Outcome data are very promising. If you look at the LDL reduction, it is almost in the range of 50%. So previously it was like and LDL used to go down in the range of say about 30 or 40, and it is very well tolerated. There was practically no side effect. Outcome data clearly tells in both the studies that if you use PCSK9 inhibitor, reduce the LDL significantly, the outcome is there above the benefit of atorvastatin and above the benefit of ezetimibe. And when the risk is high, the benefit is high. So that we have to keep in mind that in high-risk population, definitely this is a good molecule. At the same time, if the baseline LDL is high, suppose to start with the patient is having LDL of 210 or 230, and you are giving the molecule like PCSK9 inhibitor, the beneficial effect is definitely more. As far as safety is concerned, practically it's a very safe molecule, no increase in diabetes incidence, no muscle dysfunction or myalgia, no neurocognitive dysfunction. Only problem is local site injection might be thing, or sometimes a flu-like symptom is the only side effect of this molecule. All guidelines are clearly mentioning that this should be used in most of our patients. Along with the atherosclerotic disease, if the patient has a strong family history, okay, then also it's an indication that PCSK9 inhibitor should be used in most of the patients. So whenever FDA has approved this for both familial dyslipidemia, at the same time clinical atherosclerotic disease, where the patient falls into high risk. Now this is the patient who is having a recurrent cardiovascular event, 69-old, prior MI before 1 year. Patient has undergone angioplasty, patient was on atherosclerotic 80 milligram, patient is a diabetic patient, LDL was 70 milligram. And in spite of this, I mean, patient, and again, the patient has recurrent event. Okay, previously there was a LED block. Now the patient has significant block in the RCA, and patient has to undergo another procedure. So a recurrent event, whenever it's occurring in a patient who is in LDL of 70, okay, we have to think that still more reduction may be required. So what the guideline tells, that whenever there is a recurrence of event within say 1 or 2 years, and you have to have the target LDL level, it is not 70, it is not 55, it is 40 milligram. So we have to reduce LDL to 40 milligram. Now this patient, suppose we give ezetimibe, it may reduce the LDL to about 10 or 15 milligram, but may not go to the LDL target of 40 milligram. And PCSK9 inhibitor is a very, very powerful agent. It can reduce the LDL to the target level which we want to achieve, especially in this type of patient where there is a recurrent event and the LDL is still overall okay 70, but not good for in this patient. PCSK9 inhibitor with atorvastatin, high dose, and ezetimibe can reduce the LDL to almost 85%. Okay, so this three combination is very useful when you want to achieve a really significantly LDL target as a lower. Another patient is there, 32-year-old patient. He has a non-STEMI. LDL baseline was 210 when the first time intervention was done. Atorvastatin 80 milligram was started. Her LDL after 30 days has gone to 125. So definitely it has reduced, but it has not reduced to the target level. What they say is in acute coronary syndrome patient, if within 4 to 6 weeks, if LDL is not reaching to the target level, then you have to add another agent. And in this case, definitely ezetimibe may be a good option to start because it can still further reduce LDL to about 10%. So patient was put on ezetimibe. LDL now is 103. Okay, to start it, this was 210, now it is 103. So it has reduced to 50%, but still it is not to the target level. In this group of patient, high risk patient, where a patient is having multiple risk factor, definitely LDL should be in the range of 70. And definitely this kind of patient, as we can see here, you have to have at least 50% reduction in the LDL. At the same time, LDL baseline value should be less than 55. So both the things should be there. If anyone of this thing is not there, definitely we have to add another antiplatelet agent. So definitely we have to consider PCSK9 inhibitor this of patient because in spite of ezetimibe and high dose of atorvastatin, target LDL is not achieved in this group of patients. Difference between 2016 guideline and 2019 is very high risk patient. Previously, the guideline was telling LDL target of 70. Now it is telling LDL target of 55. In a patient who is another important thing is there has to be more than 50% reduction as well as there has to be LDL less than 55. So both things should be there. 50% reduction should be there. So baseline LDL is say suppose 110, it has gone to say 55, but still it is not achieving the target. So both combination has to be there in this group of patients. So alone 50% reduction is not sufficient. When it is a high risk group of patient, previously it was 100, now it is 70, and with the moderate risk, it is in the range of about 100. So definitely we know that PCSK9 is a very costly molecule. The efficacy wise, if you cost effectiveness wise see, high risk patient, as I have mentioned, is going to benefit in most of the patient and it should be used. As I have told, the patient who is having moderate risk or a relatively low risk, then LDL target should be in range of 70 or 100. Another clinical scenario, this is a person who is having gone executive, gone for the CT angiography report. There is a strong family history, age of the patient is 52, and patient is already having diabetes. Diabetes is reasonably well controlled with the medicine. His calculated LDL is in the range of 180, and the calcium score was definitely high. And if you look at the atherosclerotic risk calculator, it is estimated to be 9%. So what guideline says, whenever there is a family history, and along with that, there is another risk factor, like this patient is a diabetes, so basically it falls into a high risk group of patient. And here also the target should be in the range of about 55 and not 70. So strong family history, along with that, if there is a diabetes, risk score is high, calcium score is high, then definitely target should be less than 70. And alone ezetimibe may not be even sufficient. We have to take the advantage. I mean, we have to use the PCSK9 inhibitor synthesis to a patient. Another clinical scenario, patient is, Anish has mentioned, cannot take statin in spite of using different doses, different combination. Still, patient's LDL is very high. Definitely, if atherosclerotic risk calculator shows a very moderate to high risk, then a PCSK9 inhibitor should be used. Another important thing is when we counsel the patient, because we have to start the medicine which is very costly. So we have to counsel the patient that this is the molecule which is really required in this in your set. We can tell that outcome data is there, which gives a clinical benefit. At the same time, we can always tell that the plaques will be reduced and event rate also will be reduced. And if them counsel them properly, definitely they may take this molecule when the indication is there. This is the uh, suppose a patient is having started on the evolocumab, that is Repatha, which has been started 140 milligrams subcutaneously injection, and patient comes after follow-up. What kind of side effects we expect in this group of patient? Is it muscle related, neurocognitive, new onset diabetes, or injection site reaction? So basically, it is an injection site reaction. There is no high chance of or high incidence of muscle-related side effects with PCSK9. Neurocognitive dysfunction is practically same as we have seen in the trial, which is they have used for about 5 years. And new onset of diabetes, which is sometimes seen with the statin, also is not that high. So only side effect practically we can say is the injection-related side effect. And suppose the LDL, if it is going down in this group of patients, how much you can expect? We can tell that it can reduce the LDL in the range of about 85%. Okay, if there is a combination of three molecules, then definitely 85% LDL reduction can be achieved. Thank you very much. If you have any question, one or two, we can answer. Or yes, sir. Yes, sir. That's a very important question. I have used in couple of patients. Okay, PCS inhibitor, it gives a very dramatic result. What I normally do is, standard dose is about 15 days. Okay, so twice a month it should be given. You are right, it should be given for a longer time. Okay, many of our my patients had recurrent events. LDL was remaining in the range of about 130 in spite of high dose, and have given it. What I many a times do, okay, which is not a scientific, but I can reduce. I have done in couple of patients. I have reduced once a month. Okay, so initially I started with a 3 months. LDL has gone down. Then I reduced the dose from 15 days to 1 month therapy, and patient is still maintaining a reasonable LDL level. Okay, so this is not a scientific. It should be given twice a month, but practically you can do this thing. And many times what I tell to the patient, this is a good molecule. It is very effective molecule. Let's try in your patient. Okay, just take 2 or 3 injections. If 2 and 3 injections is reduced, then we will continue. Because I know that LDL is going to go down. Okay, but many a times to try to convince the patient, I tell them that let's see. It's a very costly molecule. It may be effective, may not be effective. If it is effective, we'll continue for longer time. And at the same time, I tell them that initially try standard, that is twice a month. And later on, we may think if LDL is significantly reduced, I can. So many of my 2 or 3 of my patients are on once a month, and they're still maintaining the LDL in a reasonable value. So cost also is a little bit safe. Yeah, yeah. Yes, yes, yes. Rosuvastatin 40 milligram. 40 milligram rosuvastatin, then start ezetimibe, and if it is not controlled, but many times, if the target and the baseline LDL is quite different, like see, patient's LDL target is say 40, and right now the patient's LDL is say 110. We don't expect that alone ezetimibe is going to take care. Okay, we may give scientifically, let's say, but we have to keep in mind that it's not going to get our target achieved. Okay, so we have, mostly this patient will require. Many times I tell that let's start one molecule ezetimibe. If it is not well controlled, then this possibility needs to be taken. And next time when the report comes, it may not be very low. And I always tell my patient that this is target. Okay, so people also, a person also is little bit concerned. Okay, I'm not the only person who is concerned that this target should be achieved. So what I tell that your target is say 55. So he also will be thinking whenever he comes with the report, sir, this time it is high. Like 100. So he immediately will think now what to do, and then we can give a suggestion that PCSK9 is 18,000 rupees. So it's going to be like 8-1 injection. So it's going to be, they are going to reduce the price. There is a discussion going on, but right now this is the price. But I've used it in many of the patients, and result is very good, very good. So thank you, everyone. Now there are a couple of questions which I'm going to answer now. First question which has been asked is, what is the evidence of reducing LDL to less than 1.4 milliequivalent? That means it's around say 55 or 60 milligram. Is there is any evidence for this or not? I would like to answer this question. There are evidences that if you reduce the LDL to say in the range of say 40 to 55, there is an additional advantage, especially for the regression of the plaque. Okay, so if you want to make the plaque regress, then you have to LDL to this drastic low level. If you say achieve your LDL level in the range of say 70, then it can stop the, I mean, it can prevent the progression of the disease, but it may not be effective or may not be very helpful to reduce the plaque or to regress the plaque. And that is the reason we have to have this. So evidence is there, both intravascular ultrasound and the clinical evidence is there, that if you reduce the LDL to drastically low in the range of say 40 or say, then there is a definite advantage of using this molecule. So, so answer is very clear that there is an evidence, both clinical as well as intravascular ultrasound have also shown that regression of the plaque can be achieved if you reduce LDL to less than 1.4 milliequivalent. So that is important thing. Second question is how you approach in a high risk group of patient. Now, this guideline, which is recent ESC guideline, is clearly focusing on the high risk population. And what they're recommending is that if the patient falls into high risk group, then you have to be more aggressive. They are not recommending that you should be. I mean, they're recommending that if the patient is not falling into high risk group, if it is in a low risk group, then you may not be that much aggressive. So in high risk group of patient, which is clearly mentioned in the group that this is the like high risk group, like patient is having diabetes, patient having kidney disease, patient multiple event, patient having recent acute coronary syndrome, a strong family history. These are the high risk group of patient, and if it is there, then definitely we have to be very aggressive, especially in the initial time. Otherwise, the recurrence rate in this group of patient can be very high. Another question which is there, what are the parameters should be checked? I'm not on what parameters should the intensity of lipid lowering therapy should be based on. Now, as I have told, that is based on the target LDL level. Okay, and from when you are starting the lipid lowering therapy itself, we have to keep in mind that this is going to be the target in this patient. Okay, and next time when the patient comes, suppose the patient has come with the acute MI, his LDL is say in the 200 range, and at that time only you should be knowing that patient is falling into high risk group of patient, and their LDL at the end of say 6 to 8 weeks should be in the range of say about 40 to 50. Okay, and from beginning also we have to target, we have to start our therapy in such a way that as fast as possible we can achieve the target of range. So whenever the patient comes next time, if the target is not achieved, then definitely we have to increase the dose of lipid lowering agent, or we have to add on therapy, maybe in the form of ezetimibe or in the form of PCSK9 inhibitor, which is going to be very helpful. So once you know the target level, and next time check the LDL level. If LDL level is not in that range, then you have to add on therapy as far as lipid lowering therapy is concerned. Another question is, let me see. Uh, uh, how low can we go with the lipid-lowering therapy for them to be cost-effective and prudent to the patient? Now, important thing by and large is you have to have a target in your mind. Okay, so if you know the target, our purpose should that according to the guideline, what is the target for individual patient? We have to go to that level. Okay, so that is because it has been found to be helpful. Okay, now if you're looking at the cost effectiveness, I would definitely tell because it's a costly molecule, it is cost effective in a patient who is falling into high risk group of patient. If the patient is falling into low risk group patient, it may not be cost effective. So if you are combining both the things, the target level and the cost effectiveness is more there when the patient is having patient is falling into high risk group. So that also we have to keep in mind. Another question is so the same can PCSK9 inhibitor be cost effective? Yes, it can be cost effective, especially into high risk group of subset of patient. In the low risk group of patient, it is effective, but it may not be cost effective. It's a very costly molecule, and we really want to reduce the coronary event, like need for recurrent angioplasty or need for bypass surgery. That can be achieved if the patient is taking PCS inhibitor. So in this group of patient, definitely it is a cost effective molecule. Another question is how safe is the exposure to the monoclonal antibody? As I was told, it is very time-tested molecule, and that is the reason US FDA has approved this molecule. Exposure to monoclonal antibody is not doing any harm to the patient. There is no major side effect because the patients in the trials have taken it for 4 or 5 years, and it has been clearly shown, clearly checked that whether there is any major side effect is there or not. So that is not a question. It is absolutely safe as far as safe to the patient as the studies have shown, and that is the reason US FDA has approved this molecule. Otherwise, it might not have approved this molecule. How safe are the very low LDL achieved by the combination of PCSK9? Yeah, that is a very important question. This study, like 4-year study and the other studies where a triple drug combination like ezetimibe, statin, and PCSK9 inhibitor have used, they have specifically looked at the level of LDL, and what they have checked is LDL level in the range of 20. Now, whether it is causing any harm to the patient, and it has been clearly shown that if the LDL is reduced to the range of even to the range of say 20 milligram, then also there is no side effect which has been found. Okay, so there shouldn't be any fear in our mind when we are reducing LDL level to this range. Of course, guideline recommends to go to the 40 level, but suppose it goes to say 20 also, the trials have clearly shown that if you go to the 20 milligram also, it is not causing any harm to the patient. So that as far as that thing is concerned, we have to be reasonably sure that this side effect, I mean LDL reduction, if you drastically reduce this thing, it is not going to harm to the patient. Another question is, do PCS inhibitor have effect beyond LDL lowering? Yeah, very important question. LDL lowering, beyond LDL lowering, there is an additional benefit as far as Lpa reduction is concerned. So nowadays we are a little bit more concerned and focused about the Lpa. We know that Lpa along with the LDL level is an important risk factor. Okay, and previously we did not have any molecule which can reduce the Lpa. Of course, niacin was the molecule which was found to reduce the Lpa to some extent, but there was no clinical benefit which has been found. So this is the another molecule that beyond LDL reduction, this molecule can reduce the Lpa in the range of say about 25% reduction. Okay, so it is a substantial reduction which has been found in all the studies, and the clinical benefit also may be that now the patient has LDL also gone down and Lpa also has gone down. So Lpa, if along with the LDL has gone down, then clinical advantage of using this molecule will be there. So that is a very important question. I mean, beyond LDL reduction, Lpa also can be reduced. This is the probably first molecule which is found to have effect on the Lpa. Of course, now there are so many studies which are going on for Lpa reduction specifically. Okay, and nowadays we are checking this molecule. We are checking the Lpa in many of our patients. So suppose the patient comes to SIMS hospital right now with a recurrent of cardiovascular event, patient has undergone multiple angioplasty or a bypass surgery, or patient is relatively young, or patient is having strong family history. This is a group of patients we check their LDL to start with, or LPA to start with. Of course, previously we are using only LDL or lipid profile, but nowadays we are using, we are checking their LPA level. And if LPA level say range is say more than 70, they say it should be reduced. Okay, so we have to do something for the reduction of LPA also. And some another company has also started a trial for LPA reduction also. So if LPA in a patient like this, if it is a more than 70, there is an injection form of molecule. Phase 2 studies have completed, and which has clearly shown that you can reduce the LPA to reasonable extent. Okay, and the trial is now going to start where the LPA reduction is going to have a clinical benefit is there now. That is the purpose of doing this another study. So nowadays, along with the LDL, we are a little bit focused, especially in the Indian subset of patient where the coronary disease is very high. So in strong family history, LPA should be checked. And PCSK9 inhibitor is a molecule which can reduce the LPA to certain extent. Another question also is there, which statin is good in diabetic type 2 patient? Now, as such, I personally believe that rosuvastatin or atherosclerotic both are a good molecule as far as diabetes is concerned. If the patient but the important thing is it should be the high dose. Okay, it should not be like low dose. So if you are using say atherosclerotic, then the dose of the atherosclerotic should be in the range of say about 80 milligram. Okay, it should not be the low like 30 or 40, or I mean 20 or 40. And if you are using the rosuvastatin, the dose of rosuvastatin should be in the range of 40 milligram. We are not using by and large the other molecules which we were using previously, but definitely we can say that high dose of statin basically means that it is either atherosclerotic 80 milligram or rosuvastatin 40 milligram, and both are equivalent as far as efficacy is concerned. So we cannot say that one molecule is going to be more effective than the other molecule as far as LDL reduction is concerned. And definitely we can see that uh, if the LDL is then it is good. But in diabetic subset of patient, I personally don't think that there is going to be any preference of using one molecule or other. But definitely in diabetic subset of patient, our target should be very low. Okay, so after using say atherosclerotic or rosuvastatin 40 or 80 milligram, if LDL is not achieved in a diabetic subset of patient where it is going to be very low, then you might have to think of adding other molecule like ezetimibe, PCSK9 inhibitor, because the target level may be different in a diabetic patient rather compared to the non-diabetic patient. So that basically we have to keep in mind. And I suppose that is the end of all questions. Thank you all for joining me today evening. And if there are no questions, we can end this session.